All right, okay, so thank you very much for the introduction, Jason. So today, I'm going to start off our presentation and then Vanessa is going to finish us off. So just a brief introduction, QCGC Research is the Queensland Centre for Gynecological Cancer Research. The centre was established in 2003 and the mission is to research and develop the best standard of care for women experiencing gynecological cancer. So we're based up at level 6 here at UKCCR. We're quite a small team. But over the past 19 years of conducting and participating in clinical trials, QCGC Research has been collaborating with many gynecological cancer centres all around the world. We have some very strong links, especially with hospitals in North and South America, Europe, and quite a few Asian countries as well. So as we're saying, the core activities of QCGC Research is to conduct clinical trials, and these are always investigator-initiated clinical trials. But as many of you who conduct clinical trials will be aware, you can also collect a lot of other data that may lead to other studies. Some of that is biomarker studies, and that's my strength. So recently, the clinical trials that QCGC Research has been running has also been collecting tissue samples from participants as well as blood samples. So we've got a nice biobank of gynecological cancers here for doing all kinds of biomarker studies. We also collaborate a lot with Monica Jander over at the Centre for Health Services Research. She does a lot of the patient-reported outcome measures and quality of life, which are really important components of clinical trials. Also does a lot of interviews with patients to understand their experiences of being on clinical trials and what their clinical needs are, because then they can be used to inform the next trial. Obviously, when you do complete a clinical trial, it's all very well to say one practice is better than another, but for that to be implemented into healthcare, you need to demonstrate to the healthcare system that it's cost effective. So it's not going to cost more than current standard of care, or it's going to cost less. So we have cost effectiveness studies, but also, as you'll see, some of the trials that we conduct are surgical. So a lot of the trials will also incorporate a component of surgical training, both during clinical trials and after as well, to ensure that all surgeons are proficient in the required techniques. So today, I'm going to show you here's an overview of some of the trials that QCGC Research has been involved in or led over the past 19 years. In ovarian cancer, there have been trials involved in nutrition, imaging, 2 current trials that are open at the moment, ECHO and ECHO-R, and they involve looking at whether exercise during chemotherapy for ovarian cancer, either in the primary or the recurrent setting, help patient. MOST is a trial that's open that's looking at nurse-led follow-up compared to standard of care for patients with ovarian cancer. In the cervical cancer space, there was a trial with LAC that was looking at surgical trial for cervical cancer. In the vulva cancer setting, we literally just opened a feasibility study in the past couple of weeks. That's looking at groin node ultrasound to identify whether or not nodes are positive or negative. And based on that feasibility study, we're anticipating that a much bigger trial will be opened. In the endometrial cancer space, this is what the focus of today's presentation will be on. We're looking at 3 trials. One of them was closed a while ago, one closed recently, and one Endo-3 is just recruiting. But QCGC Research has also been involved in other areas. So looking at lymphedema in patients with gynecological cancers, looking at surgical training. Acumen is something that's open at the moment, that's run by Sandy McCarthy, also at UQ, and that's looking at also exercise in gynecological cancer patients, and PICO, which is looking at the process of consenting participants. So quite a wide variety of areas QCGC Research is involved in. Today, I'm just going to focus on the endometrial cancer component because all of these trials were actually initiated, managed, and led by QCGC Research. So a bit of background again about endometrial cancer. This is the most common gynecological cancer in women in Australia and also in other Western countries. It's about the 5th most common cancer. Last year, there were 3,267 new cases and 662 deaths. You look at the graph on the right, the blue line is incidence of endometrial cancers, and you can see that this line is moving upwards. There are more and more cases of endometrial cancer being diagnosed every year. This is not unique to Australia. This trend is also seen in countries like America as well. The reason why we think this is happening is because there's a very close link between obesity and endometrial cancer. Epidemiological studies have showed that about 50% of endometrial cancer cases are directly attributable to obesity, and weight loss can reduce that risk. Other risk factors are metabolic syndrome, so that's closely associated with obesity, polycystic ovarian syndrome, nulliparity, tamoxifen. Now, I'm sure many of you will have heard of tamoxifen that's given to women with breast cancer. So, you know, the benefits of giving tamoxifen for breast cancer do outweigh the risks, but there is still that risk of developing endometrial cancer in the long term. And Lynch syndrome, which is your inherited germline defects in the mismatch repair genes. And those of you who work in colon cancer will also be aware that Lynch syndrome is also a risk factor for colon cancer. I'm going to talk about the 3 clinical trials that QCGC has for endometrial cancer. The first one was LACE, which is the laparoscopic approach to cancer of the endometrium. This is a trial that was completed a few years ago. It was a massive trial, though. The idea behind LACE was that at the time, standard treatment for a gynecological cancer is to have a total hysterectomy. So that is surgical removal of the uterus, the cervix, and generally also the fallopian tubes and the ovaries as well. The way that the surgery was done at the time was a traditional open abdominal hysterectomy. So that means you're literally opening up the patient, the surgeon can see all the organs and everything that's going on, which, you know, it does the job, but the patient outcomes, you know, if you have an open surgery, you have a lot of patients who might lose a lot of blood, quite a few might end up in ICU, and the recovery can be quite protracted. So the idea behind LACE was, what if we could do a minimally invasive or a keyhole surgery instead of this open surgery for the endometrial cancers? So LACE was a phase 3 randomized equivalence trial. It involved 27 surgeons from 20 tertiary gynecological cancers in Australia, New Zealand, and Hong Kong. In total, 760 women with clinical stage 1 endometrial cancer were recruited. And this is early stage. So this is where the cancer is still confined to the uterus. So it's classed as low risk cancer. It is the most common type of endometrial cancer as well. So patients were randomized to a total abdominal hysterectomy, which at the time was the standard of care, or they received a total laparoscopic hysterectomy. And this is an idea of minimally invasive or keyhole surgery. The primary outcome was disease-free survival at 4.5 years. Most patients with endometrial cancer, if they will recur within the first 3 years. Secondary outcomes were looking at recurrence and overall survival. Now, these 760 women were recruited between 2005 and 2009, and follow-up was completed in 2016. And the primary outcomes paper was published in 2017. So this is just a graph that's taken from the paper. In the blue line, you have the total abdominal hysterectomy, which was standard practice at the time. The orange line is the total laparoscopic hysterectomy, so that's the minimally invasive keyhole surgery. This graph on the left is just showing you that the cumulative incidence of endometrial cancer recurrence, new cancer, or death is equivalent between the two groups. And on the right, just zooming in on just the cumulative incidence of death. This table here, this is showing you that the total abdominal hysterectomy on the left, that's TAH, and the total laparoscopic hysterectomy, which is your minimally invasive surgery. This is showing that at 4.5 years, disease-free survival was 81% in both groups. Recurrence was 8% in both groups. Overall survival was 92% in both groups. So really, patients had the same cancer-related outcomes regardless of what type of surgery they had. But the additional benefit for the patients who had the laparoscopic hysterectomy, which is your minimally invasive surgery, these patients had fewer post-operative serious adverse events, fewer ICU admissions. They had greater improvements in quality of life in both their early and their late recovery phases. And this extended to better physical and functional well-being years after surgery. So this is one of those trials we're actually very proud to say that LACE did change clinical practice for endometrial cancer. So now, and this is just a couple of examples of 2 clinical guidelines. So the NCCN, which is the US clinical guidelines for endometrial cancer, and the European ESGO guidelines. All of them state that the preferred surgical approach for endometrial cancer is minimally invasive surgery. And the reason for this is because you have a lower rate of surgical site infection, transfusion, venous thromboembolism, decreased hospital stays, and lower cost of care without a compromise in oncologic outcome. So that's fantastic to be able to demonstrate that this has translated into changed clinical practice. But the number one barrier to actually implementing that is actually surgeon training. So at the time when LACE was completed, they did a survey of all the surgeons, and a lot of them said, yes, we want to do laparoscopic hysterectomy, but we're not actually trained in it. So that led to the Imagine trial, which was funded by the NHMRC, and that's looking at actually training surgeons to do a laparoscopic hysterectomy, and it's recently completed, and the paper will be published soon, so watch that space. The next trial I'm going to talk about is FEM. This was a completely different style of trial, still an early stage endometrial cancer, but this is looking at a non-surgical approach, because normally women have, they have all their reproductive organs removed. If you're a young woman who's diagnosed with endometrial cancer, you're not going to be able to have kids anymore. There are some patients for whom surgery is just too high risk. And, I said before that obesity is a big risk factor for endometrial cancer. There are a lot of women who are coming through with endometrial cancer who are morbidly obese. And I'm talking about BMIs over 60, which is really quite high. So, risks of adverse events and surgery can be quite high. So FEM was designed as a phase 2 randomized clinical trial of Mirena, which is intrauterine progestin. That's actually a device that's approved by the TGA as a contraceptive. And women are randomized to Mirena plus or minus metformin or weight loss. And that's in patients, again, with early stage cancer of the endometrium. This was a phase 2 randomized controlled trial, and that completed in 2020. It involved 17 hospitals in Australia and New Zealand, and involved 165 women with early stage endometrial cancer. The primary outcome was pathological complete response at 6 months, and the secondary outcomes are predicting response to treatment. So this is just giving you an overview of randomization, because it was not one-to-one in all arms. All patients did have the intrauterine progestin, but more patients were randomized to the metformin, because we thought at the time that women who had intrauterine progestin plus the metformin might have a bit of a higher response rate. I presented this last year at the seminar series, so I'm just going to go over this very quickly. At the end of 6 months, it showed that about 60% of participants had a pathological complete response, and that means that there's no evidence of a cancer in these patients. But there's actually no way to identify who will or who will not respond to the intrauterine progestin. So we did some preliminary data, and this is what I talked about last year, where we were looking at whether or not there are any biomarkers, histochemistry or DNA mutations in tissue, or whether or not any circulating extracellular vesicles may be able to predict response to the intrauterine progestin. And our preliminary data indicated, just bear in mind this is only 8 cases, that patients who have a high level of Ki67, which is your proliferation marker, or who are mismatch repair deficient, or who have mutations in PIK3CA, ARID1A, or CTCF, will not respond to intrauterine progestin. We were very lucky to be awarded an NHMRC partnership grant just a couple of months ago. So hopefully this time next year, I'll be able to give you a bit more detailed information about this. The last trial I'm going to talk about is the current trial, which is called ENDO3. The formal name is a phase 3 randomized clinical trial comparing sentinel node biopsy with no retroperitoneal node dissection in apparent early stage endometrial cancer. This will plan to be a massive phase 3 randomized clinical trial with another 760 women involved. Primary outcomes are disease-free survival at 4.5 years and return to usual activities at 12 months. There are a lot of secondary outcomes, and a lot of these secondary outcomes have been informed by patients' needs. So there's a lot of focus on patient-reported outcomes, quality of life, perioperative outcomes, lymphedema, which is a big thing for patients with gynecological cancer, whether they need post-operative treatments, and there's also, we have a biobanking strategy involved, so we'll be collecting the patient's tissue and also blood samples as well. So I'm going to hand over to Vanessa, because she's the clinical trial manager for ENDO3. So over to you, Vanessa.
Okay. Hi, everyone. My name's Vanessa. I've been working with the unit since 2007, and I'm managing the ENDO3 trial. So this is a surgical trial predominantly, and we've got, as Eva said, the biomarkers and things later on. So standard treatment for early stage endometrial cancer includes surgery to remove the uterus, tubes and ovaries, and the removal of lymph nodes in the pelvic and para-aortic region. Multiple lymph nodes are usually removed. This is also known as a full lymph node dissection. Unfortunately, these patients that had the full lymph node dissection, approximately 30% of them would suffer from post-operative complications, including lower leg lymphedema. Sentinel node biopsy is a new surgical technique that has emerged as an alternative to the full lymph node dissection. This procedure usually involves removing 1 or 2 lymph nodes on either side of the pelvis by injecting a dye into the cervix called ICG, and it highlights the lymphatic channels to the closest node to the uterus that, should the cancer spread beyond the uterus, this will be the first node in the chain, i.e. the sentinel nodes, that it would metastasize to, thereby lowering the risk of lymphedema greatly, but not completely. Both of these surgical techniques for removing lymph nodes have significantly higher incidence of postoperative complications, lymphedema being just one of them, compared to patients that have had no lymph nodes removed. Sentinel node biopsy's effectiveness, value to patient, and potential harms, as in procedure-related morbidity, compared to not removing lymph nodes, has never been shown. It has actually been a 30-year debate whether or not patients with early-stage endometrial cancer even need to have lymph nodes removed. Some countries choose not to remove them, others do full lymph node dissections, and the sentinel node biopsy technique has taken off without actual evidence in endometrial cancer. This trial aims to determine the value of sentinel node biopsy for patients and the healthcare system, and to exclude detriment to patients. ENDO3 is the world's first randomised controlled clinical trial to determine the value of sentinel node biopsy in early stage endometrial cancer. So the trial design, it's a phase 3 open label international 2-group randomised clinical trial. We are hoping to recruit 760 patients using a 1-to-1 randomisation approach. Participants will receive either the THBSO, which is your hysterectomy, your tubes and the ovaries, and the sentinel nodes, or participants will receive the total hysterectomy without removal of the lymph nodes. So these patients are all done laparoscopic or robotically, and that was done because of LACE, that changed standard of care. So the method of randomisation into the 2 treatment groups will be minimisation, and participants will be stratified by histological cell type, grade, BMI, and age. So this is our trial schema. So we're looking at all endometrial cancer cell types, including clear cell, serous and carcinosarcoma and endometrioid, randomised to the 1-to-1. The adjuvant treatment is standardised throughout because we don't want patients that get the no-node arm being overtreated with radiation or chemotherapy because they don't have the lymph node details. And stage 1, we hope to recruit 444 patients, and then stage 2 is a further 316. So it's a long trial. It does take a while. Selection of our surgeons. Participating surgeons are required to be proven gynae-oncology doctors with a proven track record in clinical research and hospital privileges to perform the laparoscopic robotic hysterectomies and the sentinel node biopsies to be considered a surgeon for this clinical trial. To maximise trial and patient outcomes, surgeons must undergo a 2-step accreditation process and prove proficiency with the sentinel node biopsy technique. This ensures the quality of the trial is maintained and prevents surgeons being part of the trial during their initial learning phase of the sentinel node biopsy technique. Each surgeon must provide a documented minimum number of 30 de-identified cases performed as the main surgeon. The surgeon must be performing the procedure at least twice a month and detecting a sentinel node on either side of on both sides of the pelvis in at least 70% of the cases. 2 unedited videos performing this procedure must also be submitted, and these are assessed using the competency assessment tool for sentinel node biopsy by members of the Surgical Quality Assurance Committee. This tool was developed by QCGC Research in 2020. It is now an agreed, standard and validated tool that is used to standardise the surgical technique in sentinel node biopsy and for use in endometrial cancer, and provide surgical quality assurance throughout. Obviously, we need all the HREC and governance and legal contracts and everything in place before a site is able to come on board, and they must have adequate funding to be able to perform these procedures at their site, and the equipment, obviously, that is required for the sentinel node biopsy. So progress to date, we have 12 accredited surgeons that have successfully passed the accreditation: Queensland, Victoria, New South Wales, Singapore and Brazil. That's where our surgeons are located at the moment. We have a further 9 that are currently undergoing the accreditation requirements. 3 of those are in Italy, 1 in Mexico and 5 from Australia. We also have a further 10 surgeons that have expressed interest in collaboration. We have 5 sites open to date in Queensland, with a further 6 pending site requirements as mentioned previously. We have screened 399 patients since the trial opened in January 21, and we've recruited 97 participants to date. So it's going to be a big trial. It's going to take a while, but we're going to get there. And this basically, watch this space. And these are our acknowledgements. And thank you to everyone for coming in today and listening.
That's fantastic, Vanessa and Eva. I'm sure there's a pretty significant applause going on locally. There certainly is virtually here. So we have time for just a couple of quick questions. I might just ask you to both have a look around the room and see whether anyone's got their hands up, because I've got 2 questions if there's nothing there.
Any questions in the room? No, there are no questions in the room at the moment.
Great. My first question is for Vanessa. I think that being a research coordinator on an international trial is very difficult.
Yes.
If you had to encapsulate your 1 or 2 most important things that you've learned in doing that, how would you describe those to people that don't necessarily do clinical trials, let alone coordinate them like you do?
Yeah, certainly with the accreditation process, it is unfortunate when surgeons don't pass. So you are dealing with people that believe that they are experts in their field, which they are, just that our accreditation process is so strict. So you have to more flies with honey, just engage and collaborate well with them, and not get offended by the feedback. Yep. Sometimes they just need a little bit of an extra push and a bit of guidance. That's one of them. And just regular contact, just being regular contact with these sites. It just brings you to the forefront. They remember to do things, and it makes things a whole lot easier. So I've actually been collaborating with a lot of these surgeons on the LAC trial. Yep. So I've developed a very big relationship with them, and it's continued throughout, just because you're just constantly in contact, not bugging, not sending them 100 emails a week or anything, but just that regular contact, that regular touching base, remembering maybe a little personal thing about why they didn't manage to get something done, just little things that just make the relationship work better.
Good on you, Vanessa. You are a very important resource in this building, you know, all that accumulated knowledge that you have. Next question's for Eva, though. Mm-hmm. Eva, within clinical trials, there's obviously opportunities to perform what I would call a mechanistic sub-study to further understand why a clinical outcome that you see, what might explain that. Are you able to tell us about any sub-studies that are occurring in any of these current trials which are of interest? Maybe just one example, if there is one.
I think the strongest example would be the FEM clinical trial, because that's the one that's recently completed. Our partnership grant that we got is focusing on predictive biomarkers, and that's what the funding is for, but that's focusing just on baseline samples, but we also have 3 and 6 month samples. As a molecular biologist, I would love to be able to look at those samples, to be able to especially look at non-responders, because I'm very interested in why they do not respond, and if there are any new targets that we could use there. Our problem, like many other people, is funding. So absolutely the idea would be to generate a bit of preliminary data, but that is my background, and yes, I would love to be able to do that.
That's why you got the question.
Yes.
Could I just add one thing? A team here that has helped us greatly is the contracts team, legal team with Sabine, knowing all the boxes to tick for international trials. That has helped greatly, because there's things that we've got. Hey, Sabine.
I was going to say how amazing she is, but she's there. I won't say it.
Absolutely. Being able to make sure that we tick every box.
Thank you. I was just literally thinking, I have those 2 contracts sitting with me for Brazil and Singapore. Note to self. So thank you, though.
All right. Thank you, Eva and Vanessa. We might move on to Goutham now. So our next presenter is Goutham Subramanian, who works with Martin Lavin's Ataxia Research Lab. Goutham's a postdoctoral research fellow, and he's going to be talking to us about his area of excellence and expertise of treating mitochondrial dysfunction in Ataxia Telangiectasia with a novel form of anaplerosis?
Thank you, Jason, for the wonderful introduction. Just putting up these slides. Thank you. Right. Can you see the slide and hear me as well?
Yes, great. Thank you.
Thank you. So I'll just give a brief overview on the recent clinical trial that we started in March 2022. This clinical trial focuses on treating the mitochondrial dysfunction in Ataxia Telangiectasia, AT for short, with a novel form of anaplerosis using a fatty acid, basically a triglyceride called triheptamine. So I'll just give a basic background about Ataxia Telangiectasia. So AT is a very rare autosomal recessive disorder caused by mutations in the ATM gene. And as you know, ATM gene is involved in the in maintaining the genomic integrity within the cell and is involved in many aspects of DNA repair and response. So the AT has a global incidence of about 1 in 300,000 live births. And in Australia, there is just under 100 patients with Ataxia Telangiectasia. The AT manifests in the form of cerebellar degeneration, which is very progressive. And by the age of 10, these kids, as you can see here, become wheelchair bound, and they lack the ability to voluntary motion. And most of these patients also are predisposed to many forms of blood cancer. And Ataxia Telangiectasia is a multisystemic disease, which is seen in the form of ocular telangiectasia, which is basically dilation of the blood vessels in the eye. They have a dramatic immunodeficiency, which in turn causes like recurrent infections and pulmonary disease. They also suffer from chronic diseases, including diabetes and liver function defects. And AT patients are unfortunately sterile as well. Over many decades, Martin Laven's group has elucidated the different roles of ATM gene and mainly focused on ATM and its role in the DNA damage response. The group has also conducted diverse research studies using animal models of ATM, both mice and rat. It's also studied the lung structure and function, the infection, oxidative stress, the gut microbiome and respiratory microbiome. But most recently, the focus of the lab has been the oxidative stress and the mitochondrial dysfunction. And recently, Avery, as you all recognize, she published a paper that showed that the ATM deficient cells are extremely sensitive to nutrient or metabolic stress. And the paper also showed that the hypersensitivity to metabolic stress was caused by defects in ER and mitochondrial signaling caused by reduced physical contact sites. And they also noticed defects in the IP3R1, GRP-SIN5, and VDAC1 channel, which is basically the primary channel for calcium between the ER and the mitochondria. And all of this is ultimately linked to poor ER mitochondrial signaling in response to metabolic or nutrient stress. So we recently published a paper that showed that an anaplerotic approach using heptonate, which is a metabolite of diheptonine, actually corrected most of the mitochondrial dysfunction that I mentioned before in Ataxia Telangiectasia cells. So what is anaplerosis? So anaplerosis is just a process of exogenously boosting the TCA cycle. So as you can see here, the triheptonine breaks down to heptonate, which in turn converts to propionyl-CoA, succinyl-CoA, and acetyl-CoA, and feeds into the TCA cycle, thereby boosting the ATP and NADH production. And when the mitochondrial, when the energy in the mitochondria functions properly, the mitochondrial contact with ER improves, and this causes efficient transfer of calcium from the endoplasmic reticulum into the mitochondria. And calcium, as we all know, is again an important catalyst for the TCA cycle again, which feeds into the TCA cycle and boosts ATP production. So in the absence of ATM, we noticed that the ER mitochondrial tethering, the contact points, which we call tethering, is reduced, and this causes an increased sensitivity to the nutrient stress. So in the lab, we use heptonate, which I refer to as C7 because heptonate is a 7-carbon fatty acid. We use the human bronchial epithelial cells and its ATM deficient counterpart, which we refer to as B3. And we treat these cells with 2-DG, which is 2-deoxyglucose, which is a glycolytic inhibitor. It shuts off the glucose pathway, causing nutrient stress. And we observe these cells over a period of 72 hours using the InQSight. And we noticed that there was extreme sensitivity to 2-DG. And when we did the co-treatment with C7, this was significantly reduced. So as you can see here, so here in the 72-hour period, the B3 cells, which is the ATM deficient cells treated with 2-DG, underwent rapid cell killing in comparison to the control, both HBEC and B3 that's untreated. Whereas with the C7 co-treatment, as you can see here, the cell killing was rapidly brought down and was rescued. This we observed not only in the cell lines, but also primary epithelial cells collected from patients. And we also noticed that the C7 restores the ER mitochondrial physical connections in the nutrient-deprived B3 cells. So as you can see here, the connections between the ER and mitochondria taken by electron microscope. So there's almost similar connections in the untreated setting, but with the 2-DG treatment, you can notice that the connections increase in the HBEC as quantified here, but the connections remain unaltered in the B3. But with the C7 co-treatment, we observed a remarkable increase in these contact points, which is almost comparable to the control, thus enhancing the calcium transfer and all the functions that enables the signaling pathways. So basically, in summary, we found that the C7 provides multiple benefits to the ATM deficient cells. We noticed that it reduces the sensitivity to nutrient stress, induced cell killing. It increases the ER mitochondrial contact sites, improves the calcium signaling between the ER and mitochondria. And overall, there was a dramatic improvement in the mitochondrial function in ATM deficient cells. So with this research background, the National AT Clinical Team, co-directed by David Coleman and late Kate Sinclair, and also Martin Lavin and many other important clinicians, put together the clinical trial. So just as the title says, we just use the triheptonine to treat the mitochondrial dysfunction. And in this clinical trial, the AT clinic has managed to recruit 32 participants and allotted them into 3 different groups randomly. This clinical trial is mainly funded by the MRFF grant and sponsored by UQ. The clinical activities happen at UPCCR, Wesley Medical Research, and the Children's Hospital, Queensland, and is broadly supported by Brashard for the various research activities that go along with the clinical trial. So as you can see here, the groups are divided on the basis of incremental dose increase. So the first group begins with 10%, 20%, and 30%. So the clinical visits happen 2 months. So every 2 months, both the primary endpoints and the clinical parameters are being monitored by the clinical team. And the group 2 begins with the placebo and then start the 10% triheptamine, and then progressively increases along the time. The group 3 goes through 6 months of placebo and then goes on the triheptamine treatment. So we have, so I'm just going to show you some representative data because I can't show all the data here due to time restriction. So we are noticing that in some of the patients, which is obviously, this is a double-blinded trial, so we don't know who these patients are. So what we noticed is that in the first visit, we noticed the hypersensitivity to the 2DG treatment. As you can see here, in 70 to 80% of the cells were dead in the 72-hour period. But in some of the patients, we are noticing a dramatic reduction in the cell killing in the subsequent visits. And this is another example where there is a dramatic reduction in the cell killing. But there are also some patients where the rescue is not great, probably because these patients must still be on the placebo until this point of time. We only had 3 visits so far. So we are also looking at another biomarker for AT, which is neurofilament light chain. We noticed that there are papers that published elevated levels of neurofilament light chain in serum in AT patients. And I also did my preliminary study and noticed elevated NFL in the serum in the AT patients that come to the clinic. So based on this, we have also done this for the clinical trial and noticed that the NFL is slowly reducing with subsequent visits for group A and group B. And apart from this, there are also many other secondary endpoints, including the scales for assessment and rating of ataxia, International Cooperative Ataxia Rating Scale, all of which is being conducted by the clinicians. And there's also the speech and language assessment. The eye movement is being monitored by the IC-CAM, MRI lung imaging and lung function, total body potassium, and the inflammatory phenotype of the airway epithelial cells and macrophages. And we are also looking at the microbiome data for both for the upper respiratory tract and the fecal microbiome. So we've heard from the clinical team that there is some evidence of neurological improvement in some young patients who are able to sit back and involve themselves in art and things like that. And there are also other patients who are showing remarkable improvement after being involved in the clinical trial, which is very encouraging. Thank you so much.
Fantastic, Goutham. Thanks very much. Can I just ask if there's any questions in the room there? I note that Jun has a question online that we'll just ask from the room first.
There are no questions in the room.